It is my pleasure to introduce Dr. Babak J. Orandi, MD, PhD, and Master's of Science. He's the Assistant Professor of Surgery and Surgical Director of Children's of Alabama Pediatric Liver Transplant Program. He's going to talk today on obesity management and end-stage organ disease. Dr. Orandi attended the University of Michigan, where he was enrolled in the Interflex Integrated Pre-Medical Medical Program. He was a Fulbright Fellow and subsequently obtained a master's degree in clinical research at the University of Michigan School of Public Health. He spent a year at the National Institutes of Health as a clinical research training program fellow before graduating from medical school with an MD with distinction. He completed his general surgery residency at Johns Hopkins, where he completed a PhD at the Hopkins Bloomberg School of Public Health. His research is largely focused on incompatible kidney transplantation and antibody-mediated rejection. His work has been published in many peer-reviewed journals, including the New England Journal of Medicine. He recently completed an abdominal transplant surgery fellowship at the University of California in San Francisco, and I believe we have Dr. Orandi here with us today.
Thank you for that very warm welcome. I'd like to thank Dr. Farmer and Dr. Cook for the virtual hospitality and the opportunity to present today, as well as Kelly Torres and Sonia Kumar for all their efforts in helping set this day up. So let me just share my screen here. Can everyone see that?
Yes.
Looks like it. Okay. So let me start by just acknowledging my funding. I have no disclosures. And as I begin this talk, I'd like to sort of give the caveat that generally speaking, the trends I'm going to talk about are going to hold true across the different organs and their end-stage disease spectrums, but that sometimes I might present data on just one or two of those organs for the sake of time. And then the other caveat is that the literature is really plagued by selection bias, publication bias. Most of the studies that are done in this topic are single-center studies. They have relatively small sample sizes and either poor or no control populations. So it does limit our ability to draw robust conclusions. So as we think about obesity, we all know that the prevalence is increasing, and it's a global phenomenon. So whether in a low, middle, or high income country, we're seeing prevalence increase across the age spectrum. And sort of not a few years after I was born, the CDC started presenting these data, and you can see that back in 1985, the highest prevalence in the country of obesity, so BMI above 30, was about 14%. And you can see that over time, as the years have progressed, that has increased dramatically. And so you can see in the legend, they have to keep adding new category boxes as the prevalence continues to rise. And so we get to 2019, and you can see that a large swath of the country has a prevalence of obesity that's greater than 35% in the adult population. And one thing that's probably important to note in these data is that these are self-reported. And so we sort of know that people tend to round up when it comes to height and round down when it comes to weight. So we're really seeing a problem across the country. I tried to find updated data for California, and the closest I could find was from about 2012. And what you see in the state of California, if you sort of divide it into three longitudinal strips that go up and down the state, that middle strip that starts down in San Bernardino County and moves all the way up to the Oregon border is really where you have the highest prevalence, although the Sacramento area is a little bit spared, at least as of 2012. But still, high prevalences and certainly much more than just a couple decades ago. And as we look to the future, the problem is only going to get worse. So by 2030, it's expected that 1 in 2 U.S. adults will be obese, that 1 in 4 will have severe obesity, defined as a BMI over 35, and that there are certain populations, particularly women, non-Hispanic blacks, and low-income adults who are going to be particularly hard hit by this obesity epidemic. And so the reason that's a problem, obviously, we know that there's a lot of associated comorbidities that go along with obesity. And in addition, we also see that as the prevalence of obesity rises, many of these comorbid conditions actually feed into the number of patients with end-stage organ disease, and we're really starting to see that reflected in transplant waiting lists. So for example, in the pancreas transplant waiting list, the number of patients that have obesity is going up as a proportion of the overall wait list. And we see that very dramatically so in the liver transplant population. From 2003 to 2014, the number of liver transplants secondary to NASH or non-alcoholic steatohepatitis, fatty liver disease, it increased about 162%, whereas liver transplants for hepatitis C increased by 33%, and alcoholic liver disease increased by 55%. And so even though obesity is taking a more prominent place on transplant waiting lists and in the post-transplant population, the outcomes are definitely not the same. And so, for one, we can look at the heart transplant list, and you see that patients with higher BMI tend to spend a lot longer on the wait list, waiting for that organ to come. And we definitely see that in the kidney transplant population. And so these are a little bit older data that look at patients who are already listed, and we see a significant discrepancy in the likelihood of achieving transplant by BMI. So higher BMI patients are much less likely to get transplanted. And when they do have offers available, they're more likely to be turned down. We have some data that are under review right now, but we identified an incident cohort of dialysis patients that were not listed for transplant at the time that they started with dialysis, and followed them forward in time to see their likelihood of achieving waitlisting. And these are patients that that were excluded if they had any identifiable contraindication to transplant. And you can see that there's, on the left-hand panel, that time to kidney transplant waitlist is pretty dramatically different depending on what BMI category a patient falls in. And you can see the likelihood, it's about 70% lower likelihood of achieving waitlisting for patients who are in the highest BMI category compared to those who have a BMI less than 35. And then the disparity is attenuated somewhat once patients achieve waitlisting, but they still are less likely to achieve transplant. And then the reason that assuming that a patient is actually able to make it to the transplant waiting list and get transplanted, even then though, after that, their outcomes are still worse. So you can see in the left-hand panel, this is kidney allograft survival, and on the right, patient survival. We see significant disparities depending on which BMI category patients fall into. And the same is true for liver, although it should be noted that the patients with the lowest BMI really have the worst outcomes, and I think that's been sort of well described previously, and is certainly for us, at least in the places that I've been for training, that low BMI is a contraindication to transplant, just like a high BMI. So we see in the lung literature, we see, again, obese patients have worse outcomes. But when you look at it, we're talking about an absolute difference of 6%. Well, that's very, very important when you're thinking about transplant from a regulatory point of view. A 6% difference in survival is enough to close a program. But what about patients that you're evaluating either in clinic or on the inpatient side? And if you look at this top cluster of patients, these are all patients of varying BMI classes that underwent transplant. And there are significant differences depending on the BMI. But the real comparison for the patient that you're treating, the patient that's in front of you, is this, which is not undergoing transplant. We can see dramatic changes in survival depending on whether or not a patient is able to get transplanted. So the reason to care about this, though, is that after transplant, we want to ensure that patients have the best possible outcomes. And there are a lot of things a lot of comorbidities that stack up, and one of them, as we think about post-transplant, these patients are all maintained on immunosuppression. We know that weight gain after transplant is associated with diabetes or new onset diabetes after transplant, hypertension, hyperlipidemia. Corticosteroids, either indirectly through weight gain and also through direct effects, increases the likelihood of developing all of these comorbid conditions. Calcineurin inhibitors will also do the same. The antiproliferative agents and mTORs will also increase the likelihood of diabetes and hyperlipidemia. All that matters because, one, there's a higher incidence in the obese, and that it's significantly associated with a higher risk of graft loss and death. And so if we're going to have patients, if we're going to utilize these scarce resources, we really want to try to be good stewards of it, but also try to do things to optimize patients pre and post-transplant so that they can enjoy the benefits of their transplant for as long as possible. So again, in the liver transplant population, those with NASH are more likely to die of cardiovascular disease. They're significantly more likely to have a cardiovascular event the first year after transplant. And we know that a third of patients who have an MI will die within 2 years of that MI post-transplant. So these are pretty important clinical outcomes for these patients. And so as we think about how best to optimize these patients, when we think about obesity, we kind of sometimes simplify it maybe too much when we think about, well, it's diet and it's exercise, right? And it was sort of humbling when I first started on faculty, and I really spent time in clinic evaluating patients and trying to figure out, particularly for these obese patients, how do we get them to transplant? As you're counseling them about diet, you're counseling them about exercise, it's not as simple as eat less, right? A lot of these patients are in a highly catabolic state, so they need a high protein diet. And depending on which end-stage organ disease you're talking about, they have pretty complex and restricted diets. If you throw on the fact that many of these patients are diabetic and therefore need carbohydrate restrictions, and that a number of these patients will also have either acute kidney injury from hepatorenal or cardiorenal syndrome, or may have chronic kidney disease, then you see that these patients then are on pretty limited diets. Post-transplant, again, because of that catabolic state, it takes a long time for patients to really recover from that post-transplant, so we encourage a high-protein diet. In general, because of the new onset diabetes after transplant, we encourage them to be on a carbohydrate-restricted diet. Then you throw on the fact that tacrolimus causes hyperkalemia, it causes sodium retention. Many of those patients then need to be further restricted in terms of what they can eat. And then the fact that the calcineurin inhibitors in the long run lead to more chronic kidney disease. We're sort of asking these patients to follow a high protein, low carb, low fat, fluid restricted, potassium, and sodium restricted diet. And when you start to think about what it is that you can actually have your patients eat, it's really hard to figure out what we're supposed to tell these patients. And that's sort of just, if you're just looking solely at the medical aspects of the recommendations, right? This has nothing to do with the economic or social determinants of health and access to healthy food. So it's really difficult to sit there and tell a patient with advanced cirrhosis and a catabolic state and muscle wasting, well, you need to eat this and this, but because of your ascites, you can't have fluid, you can't have sodium, and so it becomes a clinically very difficult thing to talk about with patients. On the other end of that sort of weight loss spectrum is exercise, right? But we're talking about a patient population with a low EF. Many of them are short of breath, hypoxic, they have fluid retention, encephalopathic. They're not safe to go out and be on their own unsupervised. That accelerated muscle wasting, many of them have chronic fatigue and unsteady gait, so they're at risk of falls. And so we have to start thinking about more drastic interventions for these patients that are realistic. And so with time, people have started to look at bariatric surgery as a potential for some of these carefully selected patients. So if you look at these data, about 600,000 bariatric procedures are performed annually across the globe. And in the modern era of bariatric surgery, sleeve gastrectomy has really emerged as the procedure of choice for most patients. This is due to sort of less surgical complexity, comparable weight loss to a Roux-en-Y gastric bypass, fewer complications, less malnutrition, similarly improved survival compared to, or much improved survival compared to lifestyle interventions and greater weight loss, fewer reoperations, and better comorbidity resolution when you compare it to gastric banding, and sort of not inconsequentially for patients with that need liver transplant, a sleeve gastrectomy still permits you to have access, endoscopic access to the biliary system, which can be really important and helpful. And so this is, again, general bariatric literature. For those patients that we counsel about diet and exercise, after 15 years of follow-up, most of them are no different than when they started, plus or minus 2% of their body weight, whereas all these bariatric interventions lead to significant and sustained weight loss. And that ultimately translates into improved survival compared to those who don't undergo bariatric surgery. And so that's really led people to start thinking about bariatric transplant. And so this is from a systematic review we published earlier this year. You can see that there's been a growing interest, and I'll just sort of highlight that year 2019 only includes publications up to about mid-June. And so the rest of 2019 was no different. There was a big growth in the number of publications, and 2020 even more so. And so as we think about the patients with end-stage organ disease, if we think about weight loss surgery before transplant, we are considering operating on a really high-risk patient population. We spend all of general surgery being taught not to operate on cirrhotics, and here we are thinking about doing an elective operation on a cirrhotic, or someone with an EF of 15%. That puts them at significant operative risk. But some of those patients will lose weight and then gain access to the transplant list and to transplant. But what I think is most fascinating and exciting is that many of these patients will actually improve with significant weight loss. They'll improve their end-stage organ disease and then not actually need transplant at all. That's a really interesting possibility. The other option is to do weight loss surgery after transplant. Well, first, it's conditional on patients getting to transplant. So many of these patients will not survive. They're going to die because they don't get the life-saving transplant. The ones that undergo transplant first are potentially undergoing higher operative and perioperative risks, as well as the fact that all those comorbidities that we talked about are going to stack up with in the post-transplant setting, and they may end up dying of those comorbidities before they get to bariatric surgery. But there will be some patients that are able to successfully undergo bariatric surgery and then lose weight because of it. So if we look at starting with some of the heart data, it's pretty interesting. This is the largest single-center study that I could find. BMI on average for patients that underwent bariatric surgery was 53, and at follow-up was 38, compared to controls whose BMI stayed the same over that same follow-up period. So no real improvement some improvement in their New York Heart Association class of heart disease. Based on this single center, they didn't see any change in the ejection fraction, but patients had fewer CHF exacerbation admissions to the hospital and a reduction in their diuretic dose. Within our meta-analysis, we did see that overall there tends to be this sort of downshift in the severity of their heart failure classification. And we found that on average there was about 11 kilograms per meter squared reduction in BMI from the time of bariatric surgery to their last follow-up. In addition, for patients, excluding those who got transplanted, patients had an improvement in their ejection fraction from an average of 20% to 33%. And if you think about if we had patients that are sort of maxed out on medical therapy and you had a drug that improved their ejection fraction by 75%, that would be a blockbuster drug. And so what we found was that 40% of patients were able to achieve transplant listing. Another 29% of that overall cohort were transplanted. And 8.5% had sufficient clinical improvement after their weight loss that they no longer needed heart transplant. And so if you think about it, almost 50% of patients, these are high-risk bariatric patients with end-stage heart disease, were able to have a path sort of forged forward to either get to transplant or not need it at all because they had that clinical improvement. In the end-stage lung disease population, Can see this is the largest series that's out there. Only 25 patients, and it's a little bit older because it's mostly Roux-en-Y gastric bypass patients within their cohort. But you can see a median BMI of 53 down to 30 at a year post-op. You see improvements in their pulmonary function testing from pre-bariatric surgery to a year afterwards, as well as improvements in their functional status, right? So we're seeing a significant improvement in their distance traveled in a 6-minute walking test, as well as a reduction in the number of patients who needed supplemental oxygen. And so with compiling the various studies that were out there, we found that about 29% of patients were able to be waitlisted, about 7% were transplanted, and 14% had clinical improvement that precluded the need for listing. So again, we're talking about 45% of patients with bariatric surgery and end-stage lung disease are able to have a path forward. If we look at the end-stage liver disease population, the largest series comes out of UCSF, and it's sort of my time there as a fellow that got me interested in this topic more globally. And again, as we talked about earlier, one of the fundamental teachings in general surgery residency is you don't operate on cirrhotics unless you absolutely have to. And so this does require, as with all these patients, does require careful patient selection. All these patients, before they undergo a sleeve gastrectomy, obviously are going to have EGDs and treatment of their varices. If they have poorly controlled ascites, they're not going to be candidates for the operation. Their INR can't be too high, and there are no Class C cirrhotics in this group. You can see by 1 year, patients have lost, on average, about 31 kilos, with an absolute BMI reduction of about 11 kilograms per meter squared. If you look at this BMI, I sort of put a red line through the BMI of 40 because that's a pretty common cutoff for most liver transplant programs. You can see most of these patients are able to achieve that, and certainly that was the UCSF experience, where by year 24 of, I think, the 28 patients, or about 80% of patients, were able to achieve a BMI less than 40. And on that right-hand panel, you can see that their MELD score overall had a sort of a trend down, and so they didn't really see a lot of decompensation events. I think that probably speaks a lot to the selection process for sure. And then when we sort of compiled all the different studies that were out there, by 6 months, 2/3 of patients have a BMI less than 40, so within the transplantable range. And by a year, 58% were listed, 41% were transplanted, and 22% had enough clinical improvement after bariatric surgery that they no longer needed liver transplantation. So again, 80% of patients of carefully selected patients, but 80% of them that undergo bariatric surgery have a path forward to either transplant or sort of improved clinical condition. And there is precedent in the general bariatric surgery literature. I really like this study coming out of France that looked at patients who underwent bariatric surgery and had liver biopsy at the time of their bariatric surgery and then 1 year afterwards. And so in this left-hand panel, you can see over time, over 1 year, patients had a significant improvement in their overall fibrosis score, so reversal of their fibrosis. In the top right panel, you see that they have overall decrease in their NASH inflammatory activity grade on histology. And in the bottom panel, you'll see that about 36% of patients had moderate or severe steatohepatitis. But after a year of bariatric surgery, 85% had no evidence of NASH at all. So that really does hint to the possibility of what this significant weight loss can do in the setting of end-stage or advanced end organ disease. In the kidney transplant population, the largest single-center series that's out there comes from the University of Cincinnati, where they have a pretty robust program to do sleeve gastrectomy in potential transplant candidates. And not surprising, most of these patients in their series have hypertension or diabetes, or both, as the cause of their end-stage organ disease or end-stage kidney disease. And you see that they have a significant amount of weight loss, BMI average of 43 down to 36, but they have significant improvements in hypertension and their diabetes. And that really is important when we think about things that are going to kill our patients post-transplant and damage their allograft in the long run. And so here again, BMI cutoff 40 that's commonly employed, although many programs also use a BMI cutoff of 35. You can see many of these patients in relatively short order are able to achieve sufficient weight loss to be transplant eligible. And here's just a different way that they showed. You can see sort of leading up to the sleeve gastrectomy under the sort of the medical management part of their weight loss program. There's a little bit of weight loss in the beginning, although we know in the long run that tends not to be sustained. And then after sleeve gastrectomy, the weight loss is really accelerated. Now, when we look at sort of national larger data sets, looking at all patients with CKD and undergoing bariatric surgery compared to those without CKD, we see that there's no difference in mortality, although there are significantly higher operative risks, AKI, kidney injury, that sort of thing. And then for patients in the end-stage renal disease population, there's 11.5-fold higher odds of death undergoing bariatric surgery. This is 30 days post-bariatric surgery, so not inconsequential, as well as those increased risks of reoperation, intervention, readmission. There's some more recent data that's come out from the University of Michigan group that is looking specifically at sleeve gastrectomy, where they don't see any difference in mortality, although they still see increased length of stay and increased readmissions. All these things do matter, as we think about the patient that we're caring for in front of us. We want to do what's right for that particular patient, but when we step back and think programmatically, all these things are important from a transplant program point of view, because transplant is so heavily regulated, but bariatric surgery is too, as bariatric surgery programs have to be done under the sort of the auspices of a center of excellence. And so high rates of mortality, readmissions, interventions, those sorts of things that are not necessarily risk adjusted for a patient who has end-stage organ disease, all serve as disincentives to provide a potentially life-saving service for these patients. So in our overall meta-analysis of the kidney transplant literature, we found that BMI decreased on average about 10 kilograms per meter squared. Half the patients were listed and 30% were transplanted. We found no study that described an occurrence of a patient stopping dialysis of weight loss, nor did we have any study that described an occurrence of a pre-dialysis patient who had improvement in kidney function that precluded the need for subsequent dialysis or transplant. One study did allude to a patient that was able to decrease the frequency of dialysis. I think there are probably a few factors at play here, because I do believe that significant weight loss can reverse some of the kidney injury, but most of these patients are too far gone by the time they start dialysis. And the other issue is that I think a lot of these patients, once you get on that dialysis train, you don't get off until you either get transplanted or you die. It's just sort of, you get on this hamster wheel, and it's hard to break out of that. And this is the pancreas literature. So this is, there's only one study out there, to my knowledge, that these are pancreas after kidney transplant with type 2 diabetes. There are only 5 patients, but after bariatric surgery, 3 of them actually no longer required insulin, and the 2 remaining patients that still required it had a 70% reduction in their daily requirement of insulin. And so it's pretty remarkable to see that. Now, there is the possibility of weight loss surgery after transplant. It's not well described in the heart literature. There's a single case report of a patient who had that weight gain that we talked about after transplant. They went from a BMI of 29 to 46. They had a gastric band and then lost a significant amount of weight and then had a resolution of their diabetes. But hard to take away a lot from that single case report. There's absolutely nothing out there in the lung transplant literature, probably because most of these patients either are losing the weight before transplant or they're never getting to transplant and they die. And then in terms of the literature on patients with liver disease, we see that again, a significant experience comes out of UCSF. Find that a lot of these patients will have, after they undergo their bariatric surgery post-transplant, They have significant sustained weight loss, a handful of complications, mostly those that would be sort of similar to the general bariatric surgery population, but a rather small sample size. But I'd be remiss if I didn't talk about some of the really interesting work that's going on at the Mayo Clinic by Julie Heimbach and her group, where they're doing simultaneous sleeve gastrectomy and liver transplant. So you see in this cohort they have the patients that undergo simultaneous sleeve and liver transplant are much bigger. They're more likely to have NASH. They have a BMI of almost 48 at the time of transplant listing compared to an average of 40 in some matched controls. And they're sick. These are patients with an average BMI or a biological MELD of 32 compared to 18 or 19 biological MELD for the patients undergoing liver transplant alone. You can see that the patients that get the simultaneous transplant and sleeve gastrectomy are going to have a significant and sustained weight loss after transplant. What we see in the general transplant population, and we have a lot of NASH cirrhosis here in Alabama, so that's a big part of our practice here. So we see that patients lose weight for the first few months after transplant, and that's the time we're sort of encouraging them to eat a high protein diet, and they're sort of are happy to be able to eat what they can when they want, as you know, as their appetite allows. And then over time they start to gain that old weight back, and that's when we sort of have to start talking about diet and exercise again and trying to intervene in terms of not allowing them to gain too much weight for fear that they'll end up with more of these metabolic comorbidities. What the Mayo Group found was that these patients also had significant improvements in their hypertension and their number of medications needed for their hyperlipidemia. They had a lower prevalence of metabolic syndrome, 23% compared to the 50% in the liver transplant alone cohort. And they had less steatosis on post-transplant ultrasound. When we look at the kidney literature, there's not a lot of great data on bariatric surgery after transplant. They lose weight just like the general bariatric population. It seems to be comparable to those who get it on the wait list or before listing. But again, that's of course conditional on them getting to transplant. But again, most of these data are pretty outdated. There's nothing really new in the literature for sleeve gastrectomy with a relatively low mortality rate in the cohort. And then you can see sort of this is their trajectory in a single center study of weight loss, sort of pretty significant number of kilos lost over 12 months. The thing that's, again, interesting is this reduction in their comorbidities that are all very important in terms of predicting post-transplant survival, both for the allograft and for the patient. So this patient number one is a perfect example that before bariatric surgery, they have a fasting glucose of 171 compared to 109 after they've undergone bariatric surgery. Their hemoglobin A1C comes down. There's a significant decrease in the amount of insulin they take. They're able to be liberated from metformin. They come down on their lipid medications. Patient that's on enalapril 10 milligrams TID is able to go down to enalapril 5 milligrams BID. These are all patients showed pretty significant improvements in their metabolic comorbidities. The other thing that is pretty interesting, and I think sort of gives more data to the idea that these patients will have improved graft survival with that significant weight loss. So you see that patients all have improvement in the amount of proteinuria that they have post-transplant after they've had this weight loss. So you can see that it does improve, and I suspect that will ultimately, with longer follow-up, translate into improved graft survival. Now, there's nothing in the literature about weight loss surgery in the post-pancreas transplant population. And so as we think about this sort of coincidence of these two epidemics of end-stage organ disease and obesity, you can see that obesity is playing a larger and larger role for transplant candidates and recipients, and that, of course, is going to affect outcomes at the patient level, but also at the transplant program level. We talked about how many barriers there really are to successful medical management of obese patients, particularly those with end-stage organ disease. And so bariatric surgery is becoming a more prominently used treatment modality for obesity in this patient population. But we really need better studies. If we look at the reporting recommendations from the obesity and metabolic surgery societies, there was not a single study in all the studies that we looked at that actually reported on all the things that are recommended. And so very few of these are prospective, very few of them have matched controls. And so I think we have a long ways to go to better elucidate the role of bariatric surgery in this population, who might be best served getting bariatric surgery before transplant, who might be best served getting it after transplant, what patients can we identify that may be able to reverse their course and not ultimately need transplant. All those things are still have yet to be determined, and so there's still a long ways to go. And so with that, I conclude. I'd like to thank you all for your attention and the opportunity to present today. I'd be happy to take any questions.
So, Dr. Orandi, can you hear me? This is Dr. Farmer. I just want to thank you so much for coming to visit us in Sacramento, and actually just want to let you know for certain that we will be inviting you to make a personal visit in some fashion in the future. I want to congratulate you on a spectacular presentation, and particularly meaningful for us here at UC Davis. I think you know we have one of the biggest kidney transplant programs and a large bariatric program. And I think, as you also know, Davis serves that inland portion of California that you talked about, that stripe up the middle that is disproportionately represented in our sort of obesity population, that's balanced out by, all those Bay Area and LA skinny people. So I'm just teasing. But really, really important questions for all of us, and great work that you have done. I really want to congratulate you on addressing a really important public health and population issue that will become even more important in the future. So thank you again for coming to be with us, and for a great presentation. We have a time for some questions. We'll see if we can moderate. Tan, I may have you see if you can. Are you getting any chat questions? Any questions from the audience or our colleagues? Let me grab my phone too. Zoom colleagues. Dr. Hirose, I see you coming to the microphone.
Hi, Dr. Orandi. This is Shin Hirose. You may know my brothers.
I certainly do.
We're supposed to chat later. Thank you for giving that talk. It's great. I was curious, are you looking at this in terms of adolescent transplant as well, in terms of the obesity epidemic in kids? Because I noticed that on your CV you're running the PD transplant program there at UAB.
Yes, so we haven't looked at that quite yet. It's still fairly controversial, but I think, and bariatric surgery in the pediatric population in general is still a little bit controversial, but I do think that it is going to play a very important role. We're seeing a lot of patients in their 30s here with NASH cirrhosis. I've had a few patients with hepatocellular carcinoma from it, and they're sort of really struggling to lose the weight to achieve transplant listing. So I think we're going to end up seeing a rise in the number of young patients with HCC for sure. And cirrhosis in general. So I think it's going to play an important role. When to do that, I think, is tough. The other issue that does make me a little bit nervous about that population is that we're seeing, we talk about the etiology, for example, of liver disease, and we sort of think of them as, well, this one has HCC or Hep C, this one has alcohol, this one has NASH cirrhosis, but obviously a lot of these issues are, a patient will have multiple of these etiologies at play. And so we see patients with alcohol use disorder and obesity, and particularly for patients that have gastric bypass. the effect of alcohol is much more pronounced. We know that there's a higher incidence of alcoholism in patients who've had bariatric surgery, and a lot of different theories as to why that might be. But we know that they're affected differently and more strongly and harshly by alcohol. So one drink is two for a patient who's had bariatric surgery. And so as we think about taking teenagers that are starting to get into they're transitioning towards their adult years, and it's hard to predict what their behaviors might be, especially as it relates to alcohol. And so we don't actually know if this is going to improve their outcomes, or if bariatric surgery may actually hasten their liver disease, for example. And so there's a lot to be sorted out here. Getting a whole career's worth, I think. Yeah.
Well, the good news for you is that you have a whole career ahead of you.
Right.
Dr. Cook.
Thank you, Dr. Orandi. This has been a wonderful talk. I just want to quickly note that as for a typical visiting professor day, we're trying to replicate that. So you will be meeting with Dr. Hiroshi, members of our pediatric surgery, transplant surgery, and bariatric team, as well as our research residents as well. Dr. Michael Campbell would also be traveling. Our chief of endocrine surgery will also be traveling to your institution, so probably virtually. So unfortunately, won't be able to get some of that good barbecue at Birmingham. So the question I have is, I sure you show some of the lung transplant data, and we do know that acid reflux or GERD can hasten chronic rejection of lung transplants and the development of bronchiolitis obliterans. Do you see in the literature in these lung transplant patients that undergo preoperative bariatric surgery, whether they have improved outcomes in regards to chronic rejection and bronchiolitis obliterans?
Yeah, so that's a great question, and I suspect that you're right. That's what you'll see, but we don't have. There's no data out there that I've seen, absolutely nothing reporting on really long-term outcomes, especially in the lung transplant literature. Again, we're talking about very small sample sizes. And the other issue that I sort of alluded to at the end of the talk, as part of our quality assessment of that meta-analysis, we're looking at sort of the recommendations from the Obesity and Bariatric Surgery Societies about what metrics ought to be reported, and they really are recommending that papers report on a number of different comorbidities and whether or not they resolve. One of them is obstructive sleep apnea. Almost nobody reports on that. Acid reflux, almost no one reports on that. Hypertension and diabetes are pretty well reported on, and hyperlipidemia sort of somewhere in the middle. And so my hope is that as we move forward, that people will start presenting more of those long-term data as well as more complete data, so we can know that whether or not we're helping these patients and to what degree we're helping them, or if we're not, we should know that too.
Great, thank you.
So I have one question that we'll take a couple more questions. One from our audience, our virtual audience, from Dr. Ali, who's the director of our bariatric program. It says, thank you for a very nice talk. Can you speak on how you would envision an ideal co-management program structure for patients who need transplant and have obesity, and the relationship between bariatric and transplant? And I'll just add that this is particularly timely because we are in the process of restarting our liver transplant program. You may not know that Davis actually had the first liver transplant program in the state of California.
I didn't know that.
Yeah, it's a little known piece of history, and we are in the process. Unfortunately, you really just can't drive easily from San Francisco to Sacramento, San Francisco anymore, and this is an underserved region of our community. So, to Dr. Ali's question,
Yeah,
ideal
so
organization.
That's a great question. So I think first, as we talk about co-management, I think first of all it starts at the policy level and the societal level. So I think that transplant societies, the bariatric societies, really need to work on a bit of lobbying. So part of it is that we need to carve out exemptions from CMS in terms of sort of exempting some of these patients from some of the metrics that we look at, or risk adjusting for it. And certainly when we talk about bariatric surgery center of excellence certifications, what these patients mean in terms of how it affects outcomes and certification. So I think that's an important first step. When that happens, then I think the next piece would be going to private insurers. They often will follow the lead of CMS, but I think one of the important things is that for a patient who really does have advanced end-stage organ disease, having 6 months of supervised medical management as a prerequisite to approval for bariatric surgery is not realistic. And even if patients do lose some weight, a lot of them are retaining fluid. It's hard to tell. It's what it means to fail, what it means to succeed is unclear in this patient population. But I would suspect that most of them fail, as we saw with some of those. For example, the heart study that I showed, patients have maintained the same BMI over time if they didn't undergo some form of bariatric surgery. So I think that before we could even think about it at the center level, we really have to think about it from a higher policy level to sort of incentivize programs to be able to do the right thing for the patients rather than get dinged on the back end for too aggressively caring for these patients when we think that there may actually be a real benefit to it. As far as sort of at the center level, I think we've been doing a lot more. This is sort of unrelated to obesity, but as we're looking at more patients, for example, with acute alcoholic hepatitis and limited sobriety as an indication for liver transplant, we now have addiction medicine representatives at every single one of our liver selection meetings. We now have a cardiologist at everyone because we have such a high prevalence of NASH and smoking here. And so we're trying to figure out, it really is about getting together in the same room, or I guess during COVID, on the same Zoom screen, being able to talk about each of these patients individually. I think that's really important. Ideally, you see an integrated clinic where patients can do sort of their one-stop shopping. Obviously, there's a lot of workup that goes into getting a patient ready and approved for bariatric surgery. And even more so potentially for transplant. And so facilitating all that, I think, is really important, because what I've seen is that a lot of times for these patients, their sickness really makes it hard for them to navigate the healthcare system. If you're encephalopathic, it's really hard to do all the legwork that it takes to get approved for bariatric surgery, to do all the legwork it takes to get through the transplant system and get approved. And so ideally streamlining that, wherever there are common requirements, have those sort of be shared between the two programs, so that way you can sort of have an algorithm or a fast track protocol so the patients can get what they need quickly, because what you don't want is for patients to sort of get stuck in this purgatory where they're waiting for this exam or that study, and they sort of decline to the point that they're not candidates for transplant or bariatric surgery. So I think probably the things that I would think about most is if trying to start a program like that, or it would be those aspects.
Great. Thank you. Dr. Charvet, one of our plastic surgeons.
How are you? Great talk. Quick question. So as you look at a multidisciplinary approach for weight reduction to improve the success of transplantation, have you considered or spoke with your plastic surgeons about an expanded role for plastic surgery for paniculectomy, specifically in preparation for renal transplantation? As you have massive weight reduction, we're going to be looking at excess paniculus and excessive skin.
No, that's a great question. I think the University of Maryland published a very nice series on that, showing that it was really helpful for patients. We haven't explicitly studied that. We have had, we have a lot of patients with I wouldn't say prohibitively large penises, but very difficult, certainly, that make the operation more difficult. I think it's a great idea. I think just like the literature that I presented today, looking at long-term outcomes, because what's the one thing we don't want to see is patients developing wound problems that then, as long as those wound problems are active, they're not eligible for transplant and the profound immunosuppression that goes with it. So I think we do need more data. But I think it's an interesting possibility for sure.
Thank you.
Dr. Kia, our Chief of Cardiac Surgery.
Thank you very much. I very much enjoyed your talk with tremendous knowledge. I just had a question regarding the heart transplantation part of it, because some patients have probably improved after weight reduction, especially bariatric surgery. I was wondering if you were in a series where patients were actually, as a bridge to transplantation, were given VADs and then undergone bariatric surgery, and then maybe that had an opportunity to have the VAD removed and not having to go to transplantation. Are you aware of anything like that?
Yeah, so actually, boy, I can't remember the number off the top of my head, but something like half of the patients in the meta-analysis actually had an LVAD in at the time of bariatric surgery. So, again, I would say most of the patients that had an improvement to the point that they no longer required bariatric surgery had non-ischemic cardiomyopathy as their etiology of their heart disease. And so it makes sense then that weight loss might really help with that. But many of the patients had VADs in place at the time of bariatric surgery, and many of them that did recover were able to have their VAD removed.
Right, that's good. That's very interesting. Thank you very much.
Very interesting. All right. One last question from Mike Campbell, who are one of our endocrine surgeons. The question was, do we know if the improvement on transplant outcomes is the effect of weight loss or is it neurohormonally mediated?
That is a very, very good question. And I don't think we really know. Especially I see it a lot in the liver literature. There's a lot more thought about this liver fat and liver muscle hormonal axis. And that's probably several RO1s right there, sort of trying to elucidate what the different mechanisms are. And I don't think, from what I've seen, I haven't seen anything that sort of lets us know which effect it really is or how much one plays versus the other.
Well, Dr. Orandi had the same thought, that there were several lifetimes of research opportunities in the presentation you gave this morning for lots of young faculty. So I really do think highlighting the creativity of our young faculty is, not that hearing from our senior faculty is not important, but I think both really create robust intellectual environments. So thank you for visiting. I hope you have a great virtual day with us today. Just want you to know, I'm not quite sure what the weather is in Atlanta, but it's going to be in the 60s, and everybody's, I'm sure, thinking about how to get outside later on in the day. And we wish you were with us.
The 30s this morning. So even though I grew up in Michigan, I do not like the cold. So I wish I was there in person. I'm looking forward to this visit today.
We do too. Thank you again so much. Really appreciate it.